5 West Zone. He's also the secretary of NNF Rajputana. He's also an EB from Central IAP Rajasthan for 2024. He has many index publications. He's a master trainer of many things. So I don't think so. If I continue, I would be able to do justification to what Dr. Ramesh Chaudhary is. So over to Dr. Pankaj to take the things further.
So thank you, Dr. Mukesh, and thank you, Dr. Ramesh, for gracing the occasion, and Dr. Alok, Dr. Anupam, whose brainchild this program is. And today we have a topic on lung ultrasound. I'm sure lung ultrasound is getting into our ICUs, whether it is adult ICU, pediatric ICU, and neonatal ICUs. So to do that, we have Dr. Naveen Prakash Gupta. But before that, I introduce Dr. Surinder Singh Bisht. Surinder Bisht is chairing this session today. Dr. Surinder Bisht is a dear friend, and he is at a very, very premium position. He is secretary of National Neonatology Forum, and I congratulate him for holding this post with a lot of dignity and a lot of hard work, which he is doing. Recently, they have done the North Zone Neocon in Delhi, which was a grand success under leadership of Dr. Surinder Bisht, Dr. Sushma, Dr. Naveen, Dr. Mamta Jaju, and all. So I request Dr. Surinder Bisht to say a few words about this topic, and then I'll introduce Dr. Naveen and hand over to him. Dr. Surinder, please.
So thank you, Dr. Pankaj, for such a kind word. In fact, this was a little hyperbole, but thanks for this. And first and foremost, I must thank Dr. Anupam Sachdev, sir. Despite all this, such a senior person is so humble, and he carries forward, and he has started this program with the help of people like Pankaj Garg, Naveen Gupta, and Mukesh, and support of Dr. Alok Bhandari. This program is certainly going a lot of places and is much appreciated. I must thank my dear friend Ramesh Chaudhary. So, मैं तो राजस्थान से हूँ, so I have Rajasthan connection with Ramesh Chaudhary. Okay, so thank you, Ramesh, for helping us, guiding us in all our endeavors. Naveen, I'm really surprised. After this North Zone Neocon, such hectic parlays over months, and so you guys still have energy to come forward and teach. Hats off to you. I'm really thankful to you. It was wonderful. And as far as lung ultrasound is concerned, I think it is not just entering. It is now part and parcel of all the care which is being provided in most of the NICUs. It is simpler than certainly doing an echo. And it is certainly, you can say, more helpful in many ways than an echo. In echo, while you're doing an echo, you are still wondering whether to treat a PDA or not to treat a PDA in a newborn. Otherwise, it is other thing which you want to know from a neonatal echo is to do a shock or maybe some line. But it is still, lung ultrasound is going to give you so many different things. And I think Dr. Naveen is going to tell you the utility of lung ultrasound. It is simple, easily doable, and it is more meaningful, real time, telling you about the common conditions which you encounter in a neonatal ICU. Dr. Naveen.
Dr. Naveen Gupta is a senior pediatrician and neonatologist at Rainbow Hospital, Malviya Nagar. He is the alumni of Gangaram Hospital. He was our first DNB neonatology from Sir Gangaram Hospital, and we are proud to say that he has achieved really great heights in the field of neonatology. He is currently holding position of secretary of NNF Delhi also, and he's a dear friend. He's always there whenever we ask him to come and teach our students or teach the Delhi IAP or for all benefit of all of us. So over to Dr. Naveen Prakash Gupta for enlightening us on ultrasound of.
एक रुकावट के लिए खेद नवीन. I'll also welcome Dr. Lalan Bharti, past secretary of National Neonatology Forum, and I would also request Dr. Ramesh Chaudhary to say a few words.
Sure.
आपकी भी सुने. रमेश, आप muted हैं.
Sir, am I audible now?
Yes, yes.
It's a great pleasure to be with you all dignitaries. My thanks to Sachdeva sir and Bhandari sir. And it's always a good thing to learn the neonatal ecosography with Dinesh sir and Garg sir. And You will glad to know that I am, for the ultrasound, I am a student of Dinesh sir. So I think it's better to start academics. My wishes to all of you. Thank you, sir.
Okay. Now, sorry, Naveen, please take over then.
Right. Thank you, sir. Thank you, everybody, for the kind introduction. How to share my screen? I'm not getting option. Yeah. Okay. I have. Sir, is my slide visible, sir?
पहले थी, अब नहीं है.
अच्छा, ठीक है सर, ठीक है, 1 मिनट करता हूँ सर. अभी विजिबल है सर?
अब है, पर इसको फुल स्क्रीन कर दो ना.
अभी फुल स्क्रीन किया है मैंने सर. है फुल स्क्रीन है अभी?
हाँ हाँ, अब ठीक है.
Okay. Okay, right, sir. Right, sir. Okay. So, first of all, thank you, Dr. Anupam, for giving me this opportunity, sir, for speaking on some topic which is very close to my heart. That is the utility of lung ultrasound in neonates. And thank you, Dr. Pankaj, Dr. Surendra Vish, Dr. Alok Bhandari, Dr. Mukesh Dhankar, Dr. Ramesh Chaudhary, sir, and Dr. Lalan Bharti, everybody to be here. So basically, when we talk about lung ultrasound, so everybody, all of us know that when we talk about the vitals and when we are dealing with any sick child, or be it a newborn or be it a pediatric patient, the point of care sonography has come up in a long way in past 10-20 years. We say, suppose a child is sick and we say that, okay, his blood pressure is bad. So we want to see that what is happening inside. So we do echocardiography. We put a central line and we want to assess that whether our line is in place or not. We can locate that line with the help of the probe. Similarly, for the lungs. For lungs, it's gone are the days, or I will say that not gone are the days, but like we used to will wait, okay, how it is looking, and there is an endotracheal tube and we'll look with the position. So the lung ultrasound can take away this time. Like, it is readily available, there is no risk of radiation, you can do it. Once you give surfactant, after that also you can see that how well or how bad the aeration is. So it has come up in a big way, and it is one of the, I will not say that it is a replacement for the clinical examination or the other vitals, but it is an adjuvant, or you can consider that if you are saying that there are 5 vital signs, you can consider it as a 6 vital signs in the babies with the respiratory distress. So we need, whenever we do ultrasound, so there are few basics about the ultrasound, and what in my talk, what I will limit myself is to that what are the particulars which we need about the lung ultrasound. So first is the probe selection. So normally when we talk about the ultrasound, we have one probe, which is the sector probe, or we also call this sector probe as the phased array probe. And this phased array probe is used for echocardiography. Okay, sir, I just want to ask that whatever I am writing, is it visible on the screen or not? Dr. Anupam, एक बार बता सकते हो सर? Visible. Okay. Right. So there is a sector probe or phased array probe. Then similarly, there is a curvilinear probe. And in the curvilinear probe, it is good for ultrasound abdomen and ultrasound head. Okay. And then there is a linear probe. And this linear probe is used for ultrasound lung. What is the difference between this? So whenever we talk about any probe, there are 2 components of the probe. One is the frequency and one is the frequency. So if the frequency is less, it will penetrate more. Means we can see the deeper structures. Okay, so suppose for a sector probe for an adult, a 2 megahertz frequency is good. For a term baby, it's 5 or 6 megahertz. For a preterm baby, it's 7.5 or 8 megahertz. So more frequency is more. That means the penetration is less. We will see the superficial structure, but the resolution is good. And if you want to see the deeper structure, you will choose a probe with a lesser frequency. Curvilinear probe, they have a wide frequency, but mainly used with the lesser frequency for abdomen or for head. Now, ultrasound lung is a superficial structure. So that is why for newborn, we use the linear probe. If I talk about ultrasound lung in a elderly pediatric patient or in an adult patient, so there you can use the curvilinear probe, or there you can also use the microconvex probe. So because our talk is about the newborn, so for the newborn, because the things are very superficial, so linear probe is recommended for doing the ultrasound lung. Okay. Now about the machine, whichever machine you are using, when you put your linear probe, there will be a preset which comes, which will suggest about the lung ultrasound. So you can choose the lung ultrasound preset. Many people also choose another preset, which is by name of superficial. So because I do not know how many of you like the attendees, they are they are well versed with the ultrasound. So I will try to make point of the things which are important. So you can choose the LUS preset, or you can choose the superficial preset, doesn't matter. Then there is always an option of choosing the depth in the ultrasound. So choose a depth between 3 to 4 centimeter. So I will tell you what is the purpose of choosing this depth. And if there is an option, bring the focus at the pleural line. Now this SRI and CRI, normally they are usually turned automatically. So if you will not play too much with the machine, so these are default buttons which are there. And very, very important thing is warming of gel, specifically in newborn. When we are doing ultrasound, we want to help the child. We don't want to disturb the child. When we talk about all these neural things, if the child is sleeping and you disturb the child, that will be a bad thing rather than doing a good thing. So warming of gel is very important. There are gel warmers which come. They are not expensive. They will bring the gel to the room temperature, like to the temperature which we want, the 36.5, so that it will be good for the baby. Infant positioning and probe placement is very important. You don't want to do an ultrasound in a fighting baby. So your baby should be in a good condition. There should be a good nest around the baby, and the baby should be comfortably placed. Now, the key in lung ultrasound is when you place the probe should be, the long axis of probe should be perpendicular to the long axis of the rib. Like if this is rib, these two are the rib going, then our probe should be like this. Okay. So the probe position should be perpendicular to the long axis of the rib. Now coming to the place, where do we want to put the probe? So for newborn, we have kept the thing simple. Like we divide the area into 3 zones. Like one is the upper zone, one is the lower zone, and then one is the lateral zone. In newborn, majority of the classification, when LUS was designed, that is the lung ultrasound score, LUS score, then the posterior zone was left. But we strongly recommend, as a part of NeoScan also, which is our program, and in general, as a part of learning, that we should also scan the posterior zone. Why? The posterior zone scanning is very, very important. And now, previously, the classification was on 3 zones: upper zone, lower zone, and lateral zone. Now the posterior zone has also been involved. I will tell you why I am saying so. So posterior zone is not covered in the lung score, but we recommend it for the consolidation effusion. We want that always it should be covered. Now, when we talk about echo, like you will say, okay, 2D mode is there, color mode is there, Doppler is there, M mode is there. There are so many things. And now there are tissue Doppler is also coming up. So, but for the lung ultrasound, things are very, very simple. We want to concentrate on 2D and M mode. So what is 2D mode? 2D mode in ultrasound is black and white mode. So normally for heart, for brain, it is used to see the structure, for kidney, for everything. In lung, I will tell you that why we cannot see the structure and why do we need to look at the patterns. So, but 2D mode is a black and white mode. And what is the M mode? M mode is a mode on the ultrasound in which always on the horizontal x-axis is the time. You want to see the motion of something against the time, the movement of something against the time. Like suppose I give you an example in echo. You want to see that LV is contracting and LV is relaxing. So if you want to see that how well the against the time, how well the LV is contracting, like diameter during at the end of diastole, diameter at the end of systole, you will use the M mode. So M mode is used for a structure which are moving, which are changing their dimensions in respect to the time. So in lung ultrasound, where do we use it? I will tell you. So M mode is the another mode. So 2D and M mode. And color mode is very rarely used, sometimes to see when we have a difficulty in distinguishing between collapse and consolidation. So far what we have learned is, one is linear probe should be used in the neonatal lung ultrasound. Second is only 2D and M mode are necessary. Third is that when we place the linear probe, the long axis of the probe should be perpendicular to the long axis of the rib. Now lung ultrasound, if I have to concise it, I will concise it on a basis of 7 principles. The first thing I was telling you is that in echo, everywhere we are looking at the structure. Now, if I talk about if I talk about the principle of ultrasound, air is the enemy. If air is the enemy, so how can we see the ultrasound lung? That is why if we go to our medicine Harrison textbook, they used to say that ultrasound lung cannot be done. However, there were pioneers in this field, like Dr. Daniel Lichtenstein was one of them in 1970s or 1980s, when he refuted this fact, and he said that there are certain patterns or certain artifacts which are being generated, and they are generated as per the disease pattern, and they may help us in determining, okay, this baby is having this disease or this baby is not having this disease. So that is why in lung ultrasound, again, important point is we are not seeing the structure, we will be seeing the patterns. Now, 7 principle. The best information is obtained in 2D mode. And which probe to use? High frequency linear transducer, that I have explained to you. Second is lung signs are mainly based on analysis of artifacts. This is very, very important. Third is, how does these artifacts appear? They arise from the mingling of the air and fluid. They arise from air and fluid mingling. Fourth is, it is very important to have standardized points of analysis. Otherwise, I may be talking differently and you may be talking differently. And we have divided it into 4 zones. One is the upper zone, one is the lower zone, one is the lateral zone, and then one is the posterior zone. And all the signs arise from the pleural line. So what does this mean? Whenever we are focusing on lung ultrasound, always bring the pleura in picture, because everything is arising from the pleura. Everything is arising. And you can pick up those disorders in lung ultrasound which are in touch with pleura. And majority of the lung conditions, they are in contact with the pleura. Where if I talk about consolidation, collapse, pleural effusion, pneumothorax, RDS, everything. Most signs are dynamic. And nearly all disorders of thorax, they meet the surface. So these are the 7 principles. Okay. Now, because in one of the principles we have learned that these artifacts, they arise from the mingling of the air and the fluid. So the conditions may vary from a condition which is pleural effusion, in which there is all fluid is present between the pleura, to the pneumothorax, in which there is all air. So if I talk about air to fluid ratio in pneumothorax, there is no fluid, there is only air, so ratio is 1. In pleural effusion, the fluid is there and air is not there, so ratio is 0. And in between, based on the amount of the air and fluid, this ratio will vary. Like if I say that in normal lung, when I talk about normal lung, it's not that normal lung are completely airy. There is very minimal fluid which is present in the normal lung, which is, we say that to the tune of 2%. If I talk about a baby who is born by elective LSCS and we are suspecting transient tachypnea of newborn, it may be 3 or 4%. Interstitial syndrome in the adults, or like in TTN, it may be 5%, may be fluid. I talk about consolidation, the fluid may vary from 10 to 20%. So this is how this ratio increases. The same has been depicted here. In pneumothorax, the ratio is like it's only air, and in pleural effusion, it is the only fluid. The pneumonia or the edema, they come in between. So when I talk about putting the, so when we put the probe, this is kind of picture which comes. So let's look at, this is a 2D mode, and which transducer I am using is the linear transducer, and I have put my transducer perpendicular to the long axis of rib. So this first layer, this is the skin, then is the subcutaneous tissue, and then these things which are here, like this one and this one, they are the ribs. Okay, so when they are the ribs, because they are bony shadow, the bone, they don't allow the ultrasound wave to pass through them. When the ultrasound waves, they don't pass through them, this rib, it generates this shadow, which is called the acoustic shadow of the rib. Acoustic shadow of rib. So this generates this shadow. Now, one rib is there, one rib is there. So in between, so I am going to this static image. So one rib is there, one rib is there. And in between this is the intercostal space. And in this intercostal space, first thing you will see is the thickened white line. This thickened white line is the pleura. This thickened white line is the pleura. So unless and until you get this picture, do not move forward. So this first sign is very, very important, and this sign is called a famous bad sign. So in bad, this is the pleura, and these two are the ribs. Now you will say that, Dr. Naveen, in your picture, these are the ribs and this is pleura. Pleura is horizontal. So when this sign was made, this sign was made in the adult population with the help of the microconvex probe, in which the pleura is coming like this. So that is why in that pleura comes like something like this. So that is why this sign is, and these are the two ribs which are like in the divergent condition. However, in newborn, when we are using the linear probe, with the linear probe, the pictures come like this, and you have to imagine it that this is the bad sign. This is the bad sign. So in bad sign is made by the two ribs which make the wings of the bat, and the pleura which makes the body of the bat. So first sign is very, very important, which is that you recognize that there is a bad sign and you have recognized the pleura is there. Now, second sign is, I will just, the second thing which is very important and which we have to see is whether there is a lung sliding or not. Whether there is a lung sliding or not. And people also call it as pleural sliding. So now how do we know that pleura is sliding? If you concentrate on this image, you will see that the thick line, this thick white line. So this pleura is moving. So basically, the pleura is made of visceral pleura and the parietal pleura. Visceral pleura is in contact with the lung. Parietal pleura is in contact with the subcutaneous tissue. Parietal pleura is a fixed structure because subcutaneous tissue space is a fixed. Now visceral pleura is moving because the lung is moving with inspiration and expiration. So that visceral pleura, it glides against the parietal pleura and it generates us the picture of the lung sliding. Why this lung sliding is important is because the lung sliding tells us that we are dealing with a healthy lung. Lung sliding, when it is absent, so lung sliding can be absent in severe collapse, it can be absent in pneumothorax. So after seeing the bad sign, another thing which we need to see is the lung sliding. And lung sliding is generated by the gliding of the visceral pleura over the parietal pleura. If we have any difficulty in seeing that whether lung sliding is present or not, sometimes when you are doing it for the first time or second time, it's not very easy to judge whether you are doing it, whether the sliding is present or not. You will put the M mode through the pleural line. Important is our M mode, there is a beam which goes and it should go through the pleural line. It should not go through the rib. So when we put this vertical white line is the beam of the M mode. When it goes through the pleural line, remember that this is rib, and this is pleura. The beam should go through the pleural line. when it goes through the pleural line, this kind of picture is being generated. On the x-axis is the time, and because of the time, because this is a moving thing, this kind of picture is generated. The space from, again, it is delineating. This is skin, this is subcutaneous tissue. This thickened white line is the pleural line, and the thing which is beneath is the lung. So there are two spaces. One, this space, which is a fixed space, and the lower is a moving space. So when you have this granular kind of picture, so that means that it's a seashore sign kind of a picture, and this is suggestive of the lung sliding is present or pleural sliding is present. If pleural sliding is absent, then you will not see these granular or dotted appearance. Then you will see straighten up lines like this, and which is suggestive of the pneumothorax. So, so first sign was, what was the first sign? First thing was that we have to check, and we have to make sure that the bat sign is present. After that, we localize the pleura. And once we have localized the pleura, we will see that whether pleural sliding is present or not. Better to see it with the naked eye in the 2D image. However, if we are confused, we can always do the M mode, and in the M mode, the seashore kind of a picture. So basically, this is the beach thing in which the waves of, these are the waves, and this is the sand of the beach. So the upper fixed space is called the key space, and the lower space is called the Merlin space. This is the Merlin space. So forget about these fancy names, but whenever you have a problem with the whether lung sliding is present or absent, put the M mode, and you can see this kind of a picture. Now the third thing is, when we have reached till this point that, okay, I have recognized bat sign is present. Second is, we have recognized that pleural sliding is present. Third is whether it's a predominant A line or B line. So throughout the lung ultrasound, you will keep on hearing about A line and B line. What are A line? A line are the horizontal lines. So I will say that, okay, I will mark in the still picture. So this is the pleura. This is A line. This is A line. This is A line. So basically, they are horizontal lines. How are they generated? They are generated by the reverberation artifact. Reverberation artifacts. So basically, when the ultrasound wave is hitting the pleura, it is being reflected back. Hitting the pleura, it is being reflected back. So this kind of a reflection, by repeated reflections, it generates the artifacts. These are the reverberation artifacts which are at equidistant. Like if this is pleural line, this, and this. So they are the A lines. You can see in between also, I will mark them from the blue color. In between also, or I will mark them from the red color. In between also, there are horizontal line, but they are not A lines. So A line should be equidistant. The distance should be equidistant from skin to the pleura. Then this, then this. So they are equidistant line from the pleura. So first distance is calculated between the skin and pleura, and then whichever lines are falling at the same place. So if I summarize A line, they are horizontal hyperechoic artifacts being repetition of the pleural line due to ultrasound reverberations between the pleura and the probe. They signify high air fluid ratio. So A line, A is for air. So you can remember that like that. A is for air. So A means that lungs are well aerated. So there are only three conditions in which you can find the A lines. One is if you are dealing with the normal lung, like you do ultrasound, you scan your lung or I scan mine. If I am sitting here and I am healthy, my scan will show the A lines. Second is if there is a lung hyperinflation, if there is more air inside. In pediatric age group, maybe emphysema. In newborn, if we are ventilating and the lungs are hyperinflated. The third is disease state, which is pneumothorax. So in pneumothorax, what happens in pneumothorax? So if I say that this is a parietal pleura and this is a visceral pleura, normally there is no space between them, but in pneumothorax, there is a lot of air which is present beneath them. When there is a lot of air present beneath them, even if there is fluid here, the ultrasound waves don't reach here. So for ultrasound waves, they read air, air, and air. That is why only A lines are present. So whenever your child is very much diseased and only A line pattern is there, always suspect that you may suspect that there is pneumothorax. There are other signs which will confirm or which will defeat that whether pneumothorax is there or not. Now after coming to, I think A line, I think must be clear. So they are a horizontal line, reverbation artifact arising due to the pleura, and they are present in 3 conditions only, either the normal lung or the hyperinflated lung or the pneumothorax lung. Now coming to the second part, which is the B line. B line, they are the vertical lines. Again, they are hyperechoic line. They are arising from the pleura. So this is the pleura in this picture. This is one rib. This is one rib. Now, can you see the vertical lines which are arising? So if I freeze this, maybe okay. So if I freeze this image, maybe you can see that, okay, this is one vertical line which is arising. And when this picture is moving, you will see that there is another one which comes, okay. There is another one which comes here. And there is one which is, this is another intercostal space. So in one intercostal space we have to take. There is another one which is coming in this picture, mostly the third line. So we could see this one. So there are 3 B lines which is present in this picture. So what is B line? Very, very important feature, always present. They are comet tail artifact arising from the pleural line. If there is vertical, this is pleura. If there is vertical line which is arising from here, I will not consider that as B line. They should always arise from the pleura, always. They moves with the lung sliding. So I just take this out. Why I was not able to delineate all the 3 B lines at one point is because they were moving with the pleura. So they are moving with the pleura, right? Then features which are present most often are, they are long without fading. So suppose the one line arises from here and it fades here. Then that's not B line, that is called Z line. That is called the Z line. So forget about the Z line, but B line normally will arise from here and they will go till the end. So they are well-defined laser-like line. They erases the A line. During the path of the B line, you will not see any A line. And they are hyperechoic. So these are very, very glimpse. Just I am showing you that if you remember all this, so you will come to know, okay, this is A line, this is B line, and you will not get yourself confused with another things which are present in between. When does B line appear? Interstitial edema, a child or adult with congestive heart failure. So when the fluid starts accumulating inside the lung, then the B lines appear. In HMD, whenever there is loss of aeration, the B line will appear. In pneumonia, B line will be there, right? So either there is loss of aeration or there is accumulation of the fluid in the interstitial space, the TTN baby. There is fluid in the lung fissure. So there is a B line. So B line is not a disease always. Most of us has B line, but likely lung fissures, but we have lesser number of the B line. Like we say that in one intercostal space, 3 or more are abnormal. Conditions are CHD, heart failure, pneumonia, atelectasis, and in healthy term babies, we all understand that because the fetus womb, in the fetus, the lung is filled with the fluid. So we all have some bit of the B line. Okay. So far what we have learned, I will just revise. We go by this thing. We first see that whether the bat sign is present or not. Secondly, we see that, okay, pleural sliding is present or not. For the pleural sliding, if you want to take care of the M mode, you can take care of that M mode. The third is you see whether my pattern is A line or whether my pattern is B line. A line, 3 conditions only: normal lung, hyper-aerated lung, or pneumothorax. And B line, they suggest the fluid. Okay. Now, this LUS score, when I talk about the neonates, it is very, very important and very, very, what I will say that very, very decision-making thing, right? So there is a hell lot of clinical utility. So LUS score is made for RDS or HMD, which is a homogeneous disease. So there are 0, it goes from 0 to 3, 0 to 3. So what is 0 is when there is aeration present. So you can see that, okay, this is pleura, A line, there is no B line. That means the score is 0. It's a well aerated lung. Now, once the aeration starts, once there is loss of aeration, the B lines will start appearing. So if we see that there is 3 or more B line in one intercostal space or occupying less than 50% of the scanning area, means B line have started appearing. However, they are not too much in number. So we will see that there is moderate loss of aeration and we can score it 1. We go forward, these B line in this picture, they coalesce with each other. They come together and they coalesce with each other. You don't see any A line. There is no A line here. And the B lines, they have come closure. So this is one intercostal space, this is one rib, this is one rib, and this is pleura, right? So you can see that the B lines, they have come closure. That's why it is called coalescence of the B line. So then you score it 2. When do you score it? 3. When you see that there is coalescence of B lines and this is the pleural line. And beneath the pleural line, you can see these white dots. And those are called the subpleural consolidations. These dots are called the subpleural consolidations. Now, I will just, because you are not sitting in front, otherwise I would have asked you. So far, I was saying it consistently and I am barking upon it that, okay, the bad sign is very important, bad sign is very important, bad sign is very important. Here we have a bad sign. We have one rib, and one pleura. So these are the wings of bat, body of bat. But here we are not seeing the pleura is in continuity. So how is this a legitimate image? Yes, this is a legitimate image. Why? Because this image is being taken just next to the sternum. When we see in the newborns, specifically in preterm newborns, the ribs has not been ossified yet when it is just near to the sternum. When they are cartilaginous only, they will the ribs has not been ossified, so rib will not impart this acoustic shadow. So that is why if it is not imparting this acoustic shadow, they will come in the pleura will come in the continuity. So many times you may see this kind of picture specifically in the newborn. So don't get worried when you don't see the bad sign thing. So lung ultrasound score, I think we all are clear that okay, with score 0 is only A line, score 1 is when B lines are there, 3 or more B lines spanning less than 50% of the scan area. Score 2 is consolidation of these B line, and score 3 is when there are subpleural consolidations which are present. So what are the clinical applications? Allows assessment of the progression of disease and therapeutic approach, guiding surfactant therapy. So based on the LUS score, many people give it at a score of 8, some people give it at a score of 10, depending upon the unit guidelines. However, score of 8 is considered good, but people have seen that in this Esther trial that if we base our surfactant therapy based on the LUS score, A, we give surfactant earlier, and we all understand that giving earlier surfactant has got benefits. And B, maybe the X-ray, it's not so great or as the lung ultrasound, and you can avoid the radiation exposure also. Predicting the need for ventilatory support and similarly extubation. There are many factors now for the pre-extubation parameters based on the diaphragmatic excursion, etc., which has been established, or the lung ultrasound, based on which you can say that my baby will fall in the successful extubation or not. Assessing response to the fluid restriction. Implementation of alveolar recruitment maneuver, which is a very, very good thing for the HFO. Nowadays, we say that in HFO, we have to decide mean airway pressure based on the recruitment of the alveoli. We keep on increasing it. So lung ultrasound may help us in telling us that whether they are being recruited or not based on the A-line patterns. Okay. So now coming to the conditions. I discussed with you this case. This is a preterm baby, around 30-weeker, who got sick in the middle of the night. And if I asked you in the image, in this image, this one, so if you see that there is a bad sign present, this is one rib, and the pleura, and whether pleural lines are present, pleural sliding is present or not, because you are not sitting in front of me, I can't ask you whether it is there or not. Let's assume that this is not there. then the next, or this is there, then the next pattern is whether you see A pattern or B pattern. So this is a plain A pattern. There is no B line here. When you see a pattern, and I know that the lung sliding is not there. However, if you see A pattern, if you remember, I told you only 3 conditions it is present: normal lung, hyperinflated, pneumothorax. So this was the baby who was very sick. So who was getting sick, like he was on a FiO2 need of 21-25%, and suddenly his FiO2 needs went up. So this was not a normal lung. You can say by clinical picture also, either hyperinflated or pneumothorax. I knew that the lung sliding is not present. But if I was confused or my fellow was confused, he put the M mode here. And when we put the M mode here, we can see that this first line is the pleural line. And then you can see the horizontal line like pattern. And this pattern is called the stratosphere sign. Or many people also call this as a barcode sign.
Barcode sign.
So stratosphere or barcode sign. So this is suggestive of pneumothorax. Again, this is not diagnostic of pneumothorax, but yes, this is suggestive of pneumothorax. So I am in this picture, this is the one which suggests you that the barcode sign, and this is the normal lung. And in the normal lung, you can see that the seashore sign is present, which I explained you previously. So this was the baby in which A pattern was there. So far in this case, what we have seen is that the A pattern is there. And along with the A pattern, there is loss of lung sliding or pleural sliding is there. Okay. So what do you do next? So what happens in pneumothorax is, if I explain you in this dramatic portion, so it's not that in the pneumothorax, suppose this is the lung, and this one is the visceral pleura, and this is the parietal pleura. So air is there between the two of them. Now it's a 3-dimensional structure. So if suppose this is the lung and this is the air encircling. So it's not that air is there everywhere. So suppose air is here. So here air is there. So between this parietal pleura and the visceral pleura, if my hand is visible, so there is a loss of lung sliding. But there will be one point, there will be some point where suppose here there is a difference between parietal pleura and visceral pleura, and here they come in contact with each other. So wherever they come in contact with each other, the pleura, they start gliding again. So visceral pleura starts gliding against the parietal pleura. So there is that point is there, and that is the point which is called the lung point, where you will see that, okay, pleural sliding is there. Like in this picture, you look at these two things. There is no pleural sliding. And look at these three. There is lung sliding. So this is the pneumothorax region of the lung where only A lines are there. And this is the healthy region of the lung, where you can see that, I will not say healthy lung, but this is a moving lung where you can see that there is a B line pattern is there. So obviously there is aeration, loss of aeration here. That's why B pattern is there. But the pleura is sliding, and there is no pleural sliding. So this point is called the lung point. So what is lung point is when you slide your probe laterally, usually when the child is lying in a supine position, the air will come anteriorly. So anteriorly there is air. Anteriorly there is air between the visceral and the parietal pleura. So when you put your probe, you have a loss of lung sliding, loss of pleural sliding, and a stratosphere sign. You move the probe laterally, maybe you will reach a space where both the pleura, they come in contact with each other, and the lung sliding starts like this. And there you see this B line kind of thing, and you see that, okay, this pleura is moving. And this is called the lung point sign. And when you put the M mode, you see that when my M mode cursor goes through this was the stratosphere sign. And when my M mode cursor goes through this, and this is the seashore sign. So in one picture only, you see both the stratosphere and the seashore sign, and this is called lung point. And lung point is considered pathognomonic of pneumothorax on lung ultrasound. So lung ultrasound always identify the pleural line. If the lung sliding is absent, lung pulse. So let's leave the lung pulse because lung pulse is a characteristic feature of a large collapse. And in a large collapse also, because both the pleura will come in contact with each other, the lung sliding may be absent. So I have not covered this right now. So let's leave it for right now. Then lung sliding is absent. Then you see whether B line is present or not. If the B line is not present, that means loss of lung sliding with the only A line, that is called the A prime profile. And then you look for the lung point. If the lung point is present, it is pneumothorax. Coming to second important condition. So far we have discussed about the RDS based on the lung ultrasound score. We have discussed pneumothorax. Then another important thing is, which is lung consolidation. So lung consolidation, we again understand that in consolidation, what is happening is alveoli, they are filled with exudate or they are filled with fluid and there is loss of lung aeration. So there is a tissue pattern or liver-like ecotexture is there. So, and B lines will be there. So remember one more fact of ultrasound, which I forget to tell you, is Earth sky axis. Air comes forward and fluid goes backward. So if there is a pneumothorax and I am trying to search the pneumothorax in the posterior zone, I will never find that, because if the child is lying in a supine position, the air will come anteriorly. So I have to scan for in the anterior zone or upper zone and lower zone for the pneumothorax. Similarly, for the consolidation, because the fluid gravitates posteriorly, consolidation and collapse is something in which we should be seeing in the posterior region. So that is why we say that always lung ultrasound is complete when we also scan the posterior zone. Okay, I show you this image, this video. So this is a posterior. RTPO means RT posterior mode. So this is one rib, this is one rib, this is pleura, this is another rib. Now, between this and this, can you see that there is no pleural line? So there is a breach in the pleural line. So whenever you see breach in the pleural line, usually you will see only collapse or consolidation, specifically in the posterior zone. So there is a breach in pleural line. Now, if I tell you to concentrate on this area, concentrate in this area, you see these white dots are there. They all are exudates. And this black is the fluid. So black is fluid in ultrasound and white are the exudates. So those exudates are present in the fluid. So suppose this is alveoli and these white exudates are present. Rest fluid is giving us a black picture. And there is a breach in the pleura. So that is suggestive of the consolidation. So it may be suggestive of collapse also. The problem is that collapse and consolidation, easy to say, but difficult to distinguish on the ultrasound. And we also understand that they coexist also many times. Right? Many times we say that it's collapse consolidation. So normally people say that how to distinguish them, you put the color mode here, and in the color mode, if these exudates, they are moving, and then you can see that, okay, you can say that this is consolidation. That is dynamic air bronchogram, or static air bronchogram is when they are not moving. And air bronchogram on ultrasound is these white dots. And normally in consolidation, when you try to join these dots, this line appears, and that line is called the fractal line. Because the presentation doesn't allow me to discuss, time doesn't allow me to discuss all these things. So I'm just giving it by this. So basically, so this is the area, and we can see that, and when we put the color mode, it may help us. Okay. So in the left lung also, you do see that, if don't look at, so you can see that. Okay. So look at this area. In this area, you see the white exudates are there, and you see black, this thing is there. So whenever you see this kind of a thing, so suspect consolidation. So the arrows, this one arrow, this arrow, and this arrow, they are marking towards all this, and they are exudates, and they are called the air bronchograms. And if you try to join a line, joining these, that line is called a fractal line. So this was the area X-ray of the baby. What I want to show you is that in the X-ray, you can see that right side collapse is there, but left side pneumonia is not there. However, on the left side, there is a significant pneumonia present. In adult studies, it has been seen that the ultrasound, lung ultrasound, it carries the same sensitivity to diagnose pneumonia, keeping the CT as the gold standard. CT is considered gold standard there. In newborn, we cannot do the CT because of the risk of radiation hazard. So far we have discussed the LUS score for RDS. We have discussed a case of pneumothorax. I understand that I am going a little fast, but trying to tell you the important point. We have discussed pneumonia and the collapse part. Okay, now coming to this. This is again posterior. So whenever you talk about posterior, posterior is mainly fluid. This is one rib. This is one rib. This is acoustic shadow of the one rib. This is acoustic shadow of the one rib. Normally, in all the previous thing, you must have seen that if this is rib, the pleura should come here. But, however, where is the pleura in this picture? The pleura in this picture is this. Right? So whenever you see that the pleura is so down and this black is there, this black is the fluid. This is the visceral pleura. You are not being able to see the parietal pleura, and there is a fluid between the parietal and visceral pleura, and this whole fluid, this is the pleural effusion. So pleural effusion is something very, very easy to see, where you will see it in the posterior zone. Why? Because the fluid gravitates, first point. Second is, whenever you put a picture, you will see that from the rib to the pleura, there is a distance. So whenever you see the distance is there, and this is black in color, black suggests the fluid. So then you have this idea that, okay, this is the pleural effusion I am dealing with. Okay, so same baby with the pleural effusion. If you want to quantitate the fluid, how do you do it? You put again the M mode. You remember in the starting, I told you that we will be dealing with only 2D and M mode. So you put the M mode, and when you put the M mode, this thick, dark thing, this is the pleural fluid. And you can see this undulating thing. This is the visceral pleura. Now, why this is important? This is the parietal pleura. Parietal pleura is usually fixed, so it's not undulating. So parietal pleura will come like this. Visceral may come like this, or visceral may come like, sorry. Or visceral may come like this. Now I will be it will be easy for me to put the needle here because the visceral pleura is in distance with there. However, if I put the needle here, there is a risk that I may damage the lung because at some time, like during expiration, these two are coming in close contact with each other. So that is when you put the M mode line, you see this sinusoidal line, which is the sinusoidal wave pattern, and you can estimate the amount of fluid, or you can estimate whether you should put the needle there or not. So all this information you cannot gather on the X-ray. Okay, let's look at this picture. Let's look at this picture. So this is one rib. This is one rib. This is acoustic shadow of one rib. Acoustic shadow of one rib. Let me stop this. Okay. Okay. So you can see that there is a fluid here because the pleura is somewhere here. There is a fluid here. Along with the fluid, there is also consolidation. So this is synpneumonic effusion. This was a case of synpneumonic effusion in which if you see that, yes, there is a effusion. However, you can also appreciate that this air bronchogram is there. So this was the, okay, quad sign is also there in the pleural effusion. And what is the quad sign? I tell you. So the quad sign is when you draw one horizontal line here, one horizontal line here, one vertical line here, one vertical line here. This is called QUAD, quad sign. Basically, vertical lines are the acoustic shadow of the rib. and horizontal line, one line belong to the parietal pleura and one line belong to the visceral pleura. So this is the quad sign. This is adult picture, and this is being done with the microconvex probe taken from a book. Okay, and you can see that this is the quad line. This is one line, this one line, one line. And this is the sinusoidal thing on the M mode. You can see that how close they are coming. Okay, coming to very important conditions. So far what we have learned is RDS, pneumothorax, pneumonia, collapse, then pleural effusion. Now coming to the transient tachypnea of the newborn. So TTN is a condition in which delay in the clearance of fluid. So you will get a picture of interstitial syndrome. If there is fluid, you will get B lines. So there is a B line, but it's not that all the lung is filled with fluid. So you will get A line also. So in one picture, when you are getting B line also, A line also, this is called double lung point. I would like to clarify here that I was mentioning lung point in pneumothorax, but remember in lung point, where their A pattern was there, the pleural sliding was absent. And where B pattern was there, pleural sliding was present. Here, both in the A as well as in B, the lung sliding is present. Lung sliding is present. So when the lung sliding is present and you see both the A and B line picture, this is called double lung point. And double lung point, it's not pathognomonic. It is seen in 30 to 40% cases of TTN. Meconium aspiration, depending upon how your lung is, you can get consolidations, you can get coalescent B lines because there may be loss of aeration. You can see air bronchogram if it's more of a pneumonia picture. So it's a varying distribution. I will leave diaphragmatic excursion for now. So coming to the last slide, which is the SAFE protocol, whenever we are dealing with a sick child, how do we deal? We do an emergency ultrasound, put a probe on the heart. If there is a myocardial dysfunction, we go for the echocardiogram. If myocardial dysfunction is not there and baby is collapsing, we look for the cardiac tamponade, and it's very easy to see once we put probe in the apical region. If there is yes, we do it. If it's not there, then maybe the lung is the condition. So how do we do about the lung? Because it's a sick baby. So lung sliding is the first sign. And when lung sliding is absent, we have a suspicion of the pneumothorax. If there is only A lines, then suspicion of pneumothorax is very, very strong. Along with the lung point, we have a pneumothorax. So then we will drain it. If it's not there, then we do other things. And if lung sliding is present, but there is a lot of fluid is there, that is effusion, we can drain that effusion also. So this is called the SAFE protocol. I think this evidence I can leave for now. And so coming to the last slide of my presentation. So key point, if I have to give you, is use linear probe, use 3 areas, and do include posterior. So there will be 4 zones: upper zone, lower zone, lateral zone, posterior zone. First is bad sign, then pleural sliding, then C pattern is A line or B line. And it allows you semi-quantitative assessment of the lung aeration, predicts surfactant use, need of ventilation, response to recruitment maneuver, high sensitivity and specificity for pneumothorax, consolidation, atelectasis, pleural effusion. And let's leave the diaphragmatic thickness and excursion. However, they can be used as a very, very good predictor of extubation. Thank you very much. And my sincere thanks to Dr. Daniel Lichtenstein, who is the father of the lung ultrasound. And he runs an organization called SURF organization. And he does a 4, 5 days, 7 days training there. So I did it 2 years back. Thank you. Thank you very much.
Thank you.
Thank you. Thank you, Dr. Naveen. Over to Dr. Surinder. Yeah, please go ahead, Dr. Surinder.
So good. So as I told earlier to all the participants and attendees, and Naveen, since I knew you were teaching and I had asked all my DNBs, and I think I have 10 or 15 some numbers of my DNBs and my past SRs and junior residents all have joined. And I'm so simple because we have an ultrasound and it is so simple now to find things about lung. It is much, much simpler than actually doing an echo, and it is much more useful because we encounter these problems more commonly than having a complex congenital heart defect or in conditions where we can hardly do anything. Here we can certainly do finding a lung point, finding B lines, actually telling you about a lot of fluids, and having a pleural effusion certainly is a simpler thing to say, but knowing about seashore sign or barcode sign, these are simpler things. And in their NNF quiz now, they are getting questions about from those also,
Yes.
both in NNF quiz also. These were the questions also. I think with these words, and you made it so simple. Dr. Ramesh Chaudhary has written, it looks very simple when you teach. Okay? And this is the
Thank you,
master,
sir.
this is how a master teacher teaches and inspires others. So for all the students, do not hesitate to hold the probe in your hand and put it on a baby. Use it as of, this is less hazardous than getting X-rays done again and again and again. Thank you.
And you can tell them, sir. So thank you very much for the kind words, sir. But you can tell them that I am always there.
Dr.
So in
Chaudhary,
case
please, you like
suppose
to
they
say
have
something or some words?
Dr. Ramesh.
Hello,
Dr.
am I
Surendra,
audible?
just yeah. Yes, sir. Yes, sir. You are audible, sir.
Sorry.
Please go ahead, Dr. Chaudhary.
My regards for this excellent presentation and so elaborately presented and nicely taught. Thank you.
Thank you so much, sir. Thank you.
So, Dr. Naveen, there are some, I think, questions. There are no questions. It is only some upgradation, something. So, I think from our side, we have been, in my era, we have seen no ultrasound, and we were doing management by routine things, clinical examination, and then X-rays, and maybe very little CT scan. And now the era has come when it appears that everything is revolving with the use of ultrasound. So I'm sure you have seen both the phases. Over
Yes,
the
sir.
years, do you feel that these technologies like ultrasound, functional echoes, they have really improved the survival or quality of life of the patients? Have that evidence come, or it is just one tool which we are still finding it's making our life easier, or it is making their life better?
So I think, sir, excellent question. So there is no clear-cut evidence which suggests that specifically use of functional echocardiography has improved the clinical outcomes. So, but I think this is something which is evolving, and if we look in the last 5 or 10 years, so many papers have come, and nowadays, sir, it's like there is many a times it's very difficult in large number of things to find evidence for one thing, like clinical tool. Sometimes even clinical tool is so important, so for any investigation to come up like this. But when we are dealing with sick child, so it has always helped us. There is no downside to it, but I can tell you.
Pankaj, because RCT and the Cochrane which came about, which Naveen is referring to, about use of functional echocardiography making a difference in neonatal outcomes. Certainly, about echocardiography, not much has been found. But I certainly believe, and I think the studies are about to come, that the lung ultrasound, certainly with the position of the ET tube, the lung point actually telling you where to put your needle into. I think lung ultrasound will certainly, and the LUS scores, which so many PGs are now doing thesis. And I think when we are reviewing about LUS score for one of my PGs to do thesis, then we realize that it is such a simple tool and we can do it. So this is doable, looks more easily done, and I think less invasive. So all in all, this is a win-win situation for us without harming the baby too much and without doing any harmful treatment also. It just tells you about...
That's fine. Yeah, I'm just saying that all of us right now, there is a race. Everybody, every fellow, every resident wants to learn focus or functional echo. So that means it is just one more skill, but clinical skills will still remain important.
I agree. I 100% agree, sir. It is not a replacement. That's why that was my first line, that many a times the residents or fellows, they are putting the probe first and examining the baby later. So that's the worst thing. So there is nothing, no substitute for a good clinical examination, sir.
Thank you so much. I think that is what I wanted to listen, that this is one skill we must acquire, but at the same time, clinical skills and when to use those skills in day-to-day situation is equally important. So thank you so much, Dr. Surinder, Dr. Chaudhary, Dr. Naveen, for making this presentation an excellent presentation.
I
And
think we can't hear that.
okay then, bye-bye. Good night.
नहीं बाकी सुन रहे हैं, बाकी बात कर रहे हैं. डॉक्टर ललन has taken out time. डॉक्टर ललन की सुनेंगे. और एक I want to give a message कि हमारा flagship program of Delhi IAP Pediatric Conference of North India is now just 1 month away, and 21st 22nd September, please be there at Hayat Centric Janakpuri. And Lalan, please.
Sure. Chalo, thank you so much. Bye-bye.
Thank you. It was excellent.
Thank you, sir. Thank you. Thank you, sir. Thank you.
And
Thank
I
you
think
so much.
this is going to become a need of our for all the resident and PG. हमारे समय में तो था नहीं ये, but we are also trying to learn.
अभी भी आपका समय है सर, ऐसा ना कि हमारे समय में नहीं था.
सर, आपका ही समय आने वाला है सर.
Thank you.
Right, thank you.
Thank you, everybody, and good night.
Thank you, sir.
Ramesh.
Thank you. Good night, sir.
Thank you, Naveen and Pankaj, Waste, Lalan, and our leader Alok Bhandari. Thank you very much, and good night, everybody.
Thank you, sir. Thank you. Thank you so much, sir. Bye.
Okay.
Bye.